medic for quite time. I'm also course director for one of the other courses. I'm a practicing obs-gynec and I have been a postgraduate and undergraduate teacher for um, almost 2 decades. I teach at a university hospital. I'm a postgraduate guide. I'm a PhD teacher and all that. Okay, right. So before we start, uh, yes, Anusha, thank you. I think there are more candidates who have opted for this course, but since it's time, I think we should start. Before I start sharing my slide and go on to the topic, may I just know, Dr. Karthika and Roosevelt, what is your current academic position or practicing status? If you could unmute yourself and speak, or if you choose to write in the chat box, either of the two things will do so that I'm kind of aware of the clinical background you come from, and so I will keep the session suitable to your level. So either of you can go first. Yes. Okay. You're working as assistant professor in a medical college. All right. So you're already a postgraduate, Dr. Karthika. And Roosevelt, may I know where you are? And you finished your gynec qualification, or how is it? Karthika, you're based in India? Okay. So you're practicing obstetrician, right? Great. So wonderful. So you've opted for this course probably to gain a little extra insights. So what I would prefer and like to do is, not keep it very theoretical. See the number of subtopics which have been allotted. Has that been shared with you already? You're aware of the subtopics which we're going to deal with today? Anusha, have we shared the entire schedule with the candidates? Are you aware of that?
I will discuss with coordinator, ma'am.
All right.
Share in the group.
Dr. Karthika, have the subtopics been shared with you for the session? Or only the broad outline of antenatal complications that has been declared? Broad. Okay. All right. So if I will let you know, there are lots of subtopics which are there under this. So starting right with, approach to anemia and thrombocytopenia is the first one. And after that, I'm supposed to go on to altered LFTs, how to approach that, then how to approach patient of migraine, then lab interpretation, pregnancy, some of it, ECG, ABG interpretation in pregnancy, which is a little different from the non-pregnant. So if you see, there are a lot of subtopics which uh, I will be going through, right? So I'll start with sharing my slides. Having said that, uh, please feel free to share your clinical experience, and uh, we will pause and go over that preferably rather than, one-sided kind of. I don't want to deliver a lecture really over here. You can share your experiences or anything that you're currently uh, facing, or what you have encountered in your so many years of OBGY practice and experience, right? So we know that high risk obstetrics is a challenge in our careers, and every challenge that we face is an opportunity simply to become better than what we were before that, right? So now coming to anemia, I will not go into any theoretical discussion what is anemia, blah blah, and all that. And I think in India at least, I don't know the situation in Haiti. Over here, there's huge amount of anemia, and I think most of us do have a lot of experience in dealing with these patients. problem is that many times what we see is that people simply kind of treat all anemia as iron deficiency, which is actually not the correct way to approach things, right? So, what does one do whenever one is encountered with anemia? I would suggest that, and very simple thing, however low resource a country it is, I think the first and very simple yet very important investigation would be running a peripheral blood smear and doing the RBC indices, right? This very simple, humble test, the PBS, tells us so many things. So immediately you can see, if you can see fragmented cells, it tells you that you need to go in the direction of hemolytic. And then you go on and explore the patient and further get into the treatment modality. If the peripheral blood smear is showing no evidence of hemolysis, you can look at the RBC morphology. RBC morphology itself will give you a lot of insight into the type of anemia. For example, if it's microcytic, then the two major things which are possible is iron deficiency anemia or the thalassemia. So simply run the iron studies. If they are normal, the iron study is normal, would probably go for thalassemia. Even if your resources don't allow for HB electrophoresis, from the RBC indices itself, one can uh, go for simple things like the Mentor's index and come to a reasonable conclusion that this is thalassemia or iron deficiency anemia. If the RBC morphology is macrocytic, then megaloblastic or non-megaloblastic vacancy. Megaloblastic mostly is because of the deficiencies and simple to treat over there. Now, see, this is where the problem is. People do not look at this. And if suppose it is a macrocytic one with a background of folic acid and B12 deficiency, and you go on supplementing iron, which we see many of the, let's say, the general practitioners or people who are not really aware of these details of anemia would do, your patient will not respond. Not only will she not respond, she'll continue to have other repercussions of the deficiencies of B12 and folic acid, which we know in pregnancy can sometimes be really disastrous, right? And in the macrocytic, also there is a non-megaloblastic, then you should look for underlying disease. Here again, now supplementing the folic acid and B12 would not help, right? Now, little bit people get puzzled when the HB is less, but the RBC morphology is normal. So mostly it is because of um renal disease many times, where the erythropoietin is deficient, right? And of course, in my own clinical experience also, I have had some experience of this, that there are abnormalities of WBCs and platelets. In fact, we have ended up diagnosing aplastic anemia just with the small picture of anemia. So one must be alert. The thing about obstetricians is many times that is the first window of opportunity that we have for attending to the woman's health in general, especially in socio-eco and cultural settings like India and lots of other parts of Asia, and I think lots of other parts of certain countries where women's health are not so very much prioritized. The first time that they would be visiting a healthcare facility oftentimes is during their pregnancy. So we should be very much aware of that. Now, I have put up these charts just to give you an insight that there are lots of flow charts and algorithms which are available. If you look at the literature, you search for resources, something like this, and you could have these, these kind of flow charts handy. If you are a beginner in your practice, eventually these almost become part of our logical thinking as we progress in our own careers. There are very elaborate ones also. Then there are ones which have, if you're going into teaching, then you could go for separate charts, like, look at every type of RBC morphology, and then there is a flow chart for them, and will help you go very sequentially and very logically. You would also come across some very busy ones like this, but if one really goes through this, one single chart, you will see that it is covering almost every aspect of anemia. So, again, if you logically go and look at normocytic, macrocytic, and then see how the lines lead further, it looks very busy. I know it looks like a big jumble of things, but if you follow it in a logical sequence and you know the little background of the disease, things will be very easy with this kind of chart also. I will have the team upload the entire article from where I have taken these, and you can pull it out from the library of the course, right? Please do feel free to ask anything at any point of time, all right? This is another one in which, side by side, they've also given what can be the other suggestions over there, right? Uh, Now, where the management of anemia is concerned, I think it's easy to understand. Severe anemia at any gestational age, you'll have to go for blood transfusion, HB less than 6. And for the others, we'll have to follow what the type of anemia and the cause of the anemia is, right? Anyone would like to share anything or ask anything about uh, anemia in general, or shall we move ahead? All right. If there's no response, I'll assume that we move ahead. Okay. Okay. FCM in pregnancy. Yes, very valid question. Right. Now, FCN in pregnancy, it's a molecule which is really being pushed across by everybody. FCM in pregnancy, Kartika, the FDA has not clearly written that it is suitable for pregnancy, although probably the pharma people who might be visiting you, or many times in the conferences, people share the experiences that we are giving FCM in pregnancy, it is safe. Definitely, the rise in the HB is much more efficient as compared to the ferrous sulfate molecule and the fumarate also. The literature which they provide claims that the anaphylactic reactions are also less, but the FDA clearly has not spelled out that it can be given in pregnancy. So, keeping that medico legal aspect in mind, it's your call. Where if you want to ask my clinical experience, well, I personally reserve it for treating anemia uh, postpartum. So, we we are not giving uh, in the antenatal period because the FDA has not clearly written that it can be given safely in pregnancy. I have a lot of experience of postpartum FCM. Well, the anaphylactic reaction is much less, but it is not zero, is how I'll put it. Uh, Personally, I have been giving FCM for the past probably 5 years or so, and we have encountered a few anaphylactic reactions, although they have been very mild. All right, I hope that answers. And the rise of HB definitely is very impressive, very impressive. Much better than sulfate and fumarate. Okay, I hope that answers. Shall we move ahead? Now, thrombocytopenia. Again, this is the endpoint or something which is of more multiple etiologies, but to an obstetrician, very alarming, right? So we all know the definition of thrombocytopenia, and it affects 7 to 10% of pregnancies. There are certain literature and schools which have classified it as mild, moderate, and severe. Uh, we all can guess that the severe variety really would be alarming a situation for us. Now, the causes over here, this is where we need to focus. Again, this is a common investigation, the hemogram or the CBC, whatever terminology you're familiar with. You run a simple hemogram and then it shows you a platelet count which is not normal. Now, what does one do? First and foremost, you need to investigate what can be the cause. Now, gestational thrombocytopenia, almost every literature will mention that as number one on the list. Having said that, it should always, always, and always be the diagnosis of exclusion. One must be very alert towards the existence of HDP. Now, HDP, well, sometimes gets missed for various reason, although they sound very silly and rarely are they discussed on academic platforms. Simple things like not recording the BP properly, not recording it in the correct position, not taking the systolic BP by palpatory method, which we all learned probably in the first year of medical school, isn't it? So, revisit your patient, take the BP recording properly, run a urine protein, make sure you have done everything that you can do to ensure that your patient is not having HDP. All right. Of course, if she is in HELP syndrome, it's little difficult and really something has been grossly negligent if you missed SDP and your patient has landed up in HELP and you've not realized that she is a case of HDP, right? I think somebody else has joined us. Dr. Rajita, if you can quickly write in the chat box where you are and what you're doing currently, it would really help me understand as to what your clinical situation and experience is. Now, there are some other things which the obstetrician needs to also be aware of, like ITP, hemolytic syndrome, and hereditary thrombocytopenias. And there are certain infections. Again, in countries, most of the Asian countries have dengue going on that could be a cause of thrombocytopenia. Certain drugs are notorious which suppress the bone marrow. So now what does one do over here in thrombocytopenia? What is would put with the patient's approach? Right. Now, okay, just let me quickly read. She's a consultant gynecologist. All right, Rajita. Thank you for joining in. Now, if you look at this chart, okay, I have taken this from again an article, a very comprehensive one on thrombocytopenia and pregnancy. Now, if you look at the headings over here, these are the major causes of thrombocytopenia during pregnancy. So, if you look at the lab which has been run, it is the simple CBC, which includes the hemoglobin and the PBS. These itself will help us kind of differentiate between some of these conditions. Of course, the presence of schistocytes would definitely immediately tell you that this is not gestational thrombocytopenia, right? If it's ITP, one does not see evidence of hemolysis. Neither does one see it in hypertension unless, of course, the patient has gone into HELP syndrome. Again, it's not seen in acute fatty liver of pregnancy. So, like I said, for anemia, even over here, the peripheral blood smear would be providing so much of input in you arriving at a differential diagnosis over here. Next thing which would help us would be to run the liver function tests and look at the urine protein and look at some other features over there which will help us to arrive at a diagnosis. And of course, needless to say, the clinical evaluation of your patient will uh, be of utmost importance over here. Now, the approach to the patient of thrombocytopenia, a, a history and a physical examination, then look at the platelet size. Okay, giant platelets mostly would point towards one of the immune ones. And if the platelet size are normal, then you should think of the other uh, reasons over there. Now, how does one manage them over here? Now, in obstetrics, which platelet levels would be alarming? Now, if the patient hasn't delivered yet, then uh, one should look at 70,000 as something as a contraindication for regional anesthesia as per the recommendations. At what level does one transfuse platelets? If your patient is yet to deliver, guidelines say that 40,000 you need to transfuse. If your patient is already delivered, no signs of bleeding, then one can wait even till 30,000. People say, if some says even till 20,000 if you look at hematologist recommendation. So you need to also see what are the signs. One thing which I would suggest is uh, not just look at the gross features of bruising, bleeding. Sometimes one of the first feature would be microscopic hematuria. So it's a good idea to also look at that. And basically look at the etiology which has put your patient into thrombocytopenia. All right. For example, if your patient is of preeclampsia and or HDP as we call it nowadays and has gone into HELP, of course you would deliver the patient, no doubts about that. You would look at managing the disease condition by itself, and as soon as the HDP pathophysiology reverts, automatically the HELP syndrome would revert. Here, just giving platelets or giving, fresh frozen plasma is not going to really work until and unless the pathophysiology of the disease goes on reversing itself. Now, if suppose your patient has landed up in thrombocytopenia as a result of, say, massive hemorrhage or abruption leading to DIC, now these would be the situation where giving the fresh frozen plasma, the cryoprecipitate, and the platelets would be useful. So, along with the platelet count, one would need to also look at the prothrombin time, the APTT, the INR, the bleeding time, clotting time, right? So, these are some very general guidelines, very broad ones. Each is a topic by itself. Will not go into them. So, like over here, it says the general recommendation would be of 50,000 if you're yet to uh, do your procedure or patient is yet to deliver. Postpartum, one could wait even till 40,000. Okay. Uh, Now, like we said, postpartum, you need to continue monitoring, and postpartum hemorrhage, secondary postpartum hemorrhage could also come up, and contraceptive guidance is women. You have to see the underlying cause and give uh, the guidance accordingly. Gestational thrombocytopenia we know is because of the hemodilution and would recover. It would take around 6 to 8 weeks. And as per etiology, you'll have to follow up and look for maternal hemorrhage. For example, the ITP would you'd probably need to link them up to the hematologist and look out for neonatal thrombocytopenia. So inform the pediatrician or the neonatologist in attendance. Right? Now, the next thing which anybody would like to ask anything or discuss something or share your experience, or should we move on? This is absolutely unrelated. The next thing which has been given to me as a topic, and that is about migraine and headaches in pregnancy. So if you want to take a pause here. and talk about anemia and thrombocytopenia, we could do that, or we move on. All right. Okay. So coming to this, we know that this is the definition of migraine. Like I said, I would not be going into much of theoretical discussions over here. And we know that migraine is much more common in women as compared to men. And where pregnancy is concerned, the prevalence is reported to be 10 to 15% of pregnant women. Now, some women do experience improved uh, migraine frequency during pregnancy, especially in mid pregnancy and in the last trimester. Unfortunately, there's a lot of worsening in the episodes or in the postpartum period, oftentimes attributed to the altered sleep cycles because of the newborn care. Now, these are some of the classifications. I don't think I'll dwell much upon that. Now, during pregnancy, what causes and triggers? Well, estrogen is supposed to be one of the major implicators over here. We know that the levels change during pregnancy. These environmental factors, of course, are not pregnancy specific. Then, because of certain food cravings, the dietary triggers may also be different during pregnancy. Pregnancy itself and definitely the postpartum period brings about changes in the sleep patterns. And we know that there is alteration in the carbohydrate metabolism during pregnancy, and hypoglycemia or dehydration would also be a trigger over there, right? Now nothing very specific or different over here as compared to the non-pregnant status about the pain characteristic. But yes, the nausea and vomiting in early pregnancy sometimes would mm, kind of add to uh, the disease symptom itself, right? And we know that the sensitivity to certain smells during the first trimester gets altered during pregnancy, and that itself can be a trigger or sometimes part of the migraine. Again, fatigue and irritability are symptoms of first trimester or early pregnancy, and they would also add over here. Now, see, there can be two situations. Your patient could be a known case, or she may, again, like I said, be coming to you for the first time during pregnancy, right? So, you must rule out other causes of headaches, like again HDP, especially if she is reported after 20 weeks or more. One should never ever take a headache with HDP as just attribute it to migraine or a tension type or something like that. One should always, in HDP patients, consider it as a premonitory symptom. Now, with this migraine, does one need not resort really to imaging? If at all, MRI would be preferable over CT scan, considering the radiation. Now, where the treatment is concerned, if your patient was already on certain type of treatments, one needs to review that where safety and recommendation during pregnancy is concerned. What almost all bodies, the neurological societies, as well as the ACOG and other gynec recommendations uh, focus upon is the non-pharmacological approach during pregnancy. So, if your patient is a known case, she is already knowing that she is a patient of migraine, you should already counsel them that they should avoid the triggers, uh, avoid dehydration, avoid hypoglycemia, and have adequate rest. And we know all these stress management techniques, and each patient of migraine knows what are their specific migraine triggers. So we tell them that the non-pharmac approach would be most suitable during pregnancy and lactation. Having said that, sometimes it is not always practically possible for these women to uh, avoid things all the time, especially considering modern day lifestyles. So what about the drug therapy then? Well, paracetamol or acetaminophen is generally considered safe in pregnancy. Caffeine in moderate amounts. Recommendations say the daily intake should be less than 200 milligram. Beyond that, it's not advisable in pregnancy to cross that level of caffeine. Uh, by itself, it's not very effective, but in adjuvant with the analgesic, it does help, right? Where other drugs are concerned, there's a lot of uh, drugs today available in the armamentarium for the treatment of migraine, but most of them are not recommended during pregnancy. Where NSAIDs is concerned, a very popular group of drugs which are used for headaches, even over the counter in many places, like NSAIDs. They are best avoided in the third trimester. They can cause complications by itself. Triptans, limited use in certain patients. Ergotamines, absolutely to be avoided in pregnancy. Now, this is from the Neurological Society and the ACOG combined recommendation. So, if you see that most of the drugs, if you focus on this, see, most of them are considered with caution, not recommended, or considered with caution, right? And the safety in pregnancy mostly is about major congenital malformations, or the data is not available, right? Or these newer drugs which exist, the risks are not yet known. Okay, so if you see over here, most of these drugs which are used today are not really safe in pregnancy, or consider with caution, right? And this is about managing the acute episode. Again, if you see established efficacy and safety during pregnancy, if you again focus over here, not recommended, not recommended, not discussed, right? So acetaminophen is over here, the only one which is recommended. But you should avoid hepatotoxicity. So the number of tablets per day, and for the they say that you should not exceed even this for more than 48 hours, right? Considering hepatotoxicity. This is for managing the acute episodes of migraine over here. So migraine management in pregnancy, focus should be on prevention, right? So you could consider these other drugs over here. And for the acute episode, probably acetaminophen with caffeine does well. And well, there are lots of other things which are recommended over here. The non pharmacological therapies, like ginger, high flow oxygen. Then there are certain nerve blocks. Again, nerve blocks, not all bodies really recommend. Now, what are the risks during pregnancy? Like I said, it may cloud the diagnosis of uh, eclampsia. The warning sign of, we know that one of the warning signs of eclampsia in patients of HDP is a headache. So it may overlap with early signs of eclampsia, right? And literature is limited on this, but there are certain reports that patients with migraine may land up with preterm labor or small for gestational age women. Now we know that postpartum is a very challenging period over here for patients of migraine, right? They because the additional stress of sleep deprivation, hormonal changes, or postpartum blues, all these will compound these patients of migraine. And if these patients of migraine come to you for preconceptional counseling, one must review the drugs on which they are on. So, what does one do? Again, there are lots of very elaborate literature. I would share an article in the library. Uh, I'll ask them to upload it. Do go through that, in which very elaborately they have um discussed about how you can, in the pre-ovulatory stop their mm, treatment, and uh, I'm so sorry, in the ovulatory and post-ovulatory period, you can stop the contraindicated drugs, then wait on to see if your patient uh, has conceived. If not, then in the first half of the cycle, you can again go back to giving her the drugs for her migraine. These are women who have frequent episodes and they cannot do without their migraine medication. So, and and that article has got a lot of clinic, quite a few exemplary cases to highlight how you can manage these women in the preconceptional period, where they can continue with their medication at the same time stop it, such that the congenital malformation risk becomes minimal. Right. Uh, Now, what about these women who've got headaches, and sometimes we get a little laid back that, oh, she's a known case of migraine. So, what would be alarming in them if they get a new or different type of headache, or they get visual symptoms like blurring of vision? And of course, like we are going on harping about HDP, we cannot stress on that enough, right? And if the migraine does not respond to what we have been discussing so far about acetaminophen, it's a good idea to have a neurological review and go on to have a multidisciplinary approach to your patient's management for her headache or migraine. And if there are new additional symptoms, or the migraine pattern is different, or the headache pattern is different, again, like I said, one should not presume that it is the migraine, and explore and investigate it as a new neurological condition, best done in consultation with a neurologist. All right. Uh, any questions, any discussion which we need to do at this stage? Otherwise, I have the next subtopic. Uh, it's a little strange combination of topics which have been given. And this is altered LFTs during pregnancy. So, shall I carry on? Okay. So, let's move on and look at. Okay, thank you for that. So, let's look at this. Now, these are a very broad outline of what can cause jaundice during pregnancy. They could be pregnancy specific. Now, like a bad case of hyperemesis gravidarum, this I think most of us are familiar with. Intrahepatic cholestasis, HDP, HELP syndrome, acute fatty liver. A terrible situation to be faced with. And these are situations which any patient can have unrelated to pregnancy but can occur as a coincidence with pregnancy, like any of the viral hepatitis drug induced, and prehepatic causes like hemolytic anemia, or it could be posthepatic causes related to the bile duct. Right. What about the liver function? Is there a physiological change during pregnancy? Well, some of them do change. For example, the alkaline phosphatase we know because the placenta itself is one of the sources. 2 to 4-fold increase in the third trimester. So one should be aware as a obstetrician that these are normal changes in LFTs during pregnancies. The cholesterol, triglycerides also do increase, right? And the globulin, the alpha and the beta globulins also increase. The AST and the ALT actually are unchanged, right? Right. Now, if you look at these conditions which we spoke about, that is acute hepatitis, uh, and this is something which is very specifically seen only by the obstetrician, the intrahepatic. This is something which only the obstetrician sees, and your patient comes up with a simple symptom of pruritus. And that should be the clue for you to consider investing her for intrahepatic cholestasis. HELP syndrome, we know, is part of the HTP, and acute fatty liver pregnancy is an absolute emergency. Patients turn critical over there. So acute hepatitis we know is unrelated to pregnancy, can happen anytime. And these patients would present with jaundice and maybe with fever, nausea, vomiting. In them, very high levels of ALT and AST would be seen. Platelets, of course, would be normal. If you run the viral panel, you would uh, be able to diagnose which of them it is. Now, one needs to be very careful over here about the vertical transmission. You know that HB, hepatitis B, C have vertical transmission, and one needs to manage them accordingly. If you look at the intrahepatic cholecystitis over there, the patient presents with pruritus. LTST probably normal, very high levels of alkaline phosphatase, not affecting platelets, and alarming times they land up with even there does not cause much maternal complication but has been reported to cause a lot of fetal complication. HELP syndrome, I think we know, all know about it. I'll not dwell upon that much. Mostly seen in, I would not say just third trimester, any time after 20 weeks, whenever your patient has HDP. Acute fatty liver of pregnancy, we know, would be seen in the third trimester. Again, patient would present with nausea, vomiting, pain in abdomen. ALT, AST very high in them. Here, see the differentiating would be the alkaline phosphatase in both HELP as well as in acute fatty liver remains normal. And how do you differentiate between HELP and this? Here, the platelets are unaffected. Okay, and here the patient, what we need to focus upon this, and this is what decides our management also. The HELP syndrome patient lands up with thrombocytopenia, DIC, and has all the disasters of related to the bleeding disorder. And the patient of acute fatty liver goes into liver failure. Of course, eventually she does land up with coagulation defect and bleeds, but the very different for the two. Now, hemolytic jaundice is again something which is very challenging during pregnancy. It could be because of hereditary conditions like THAL or sickle cell or spherocytosis, or it could be because of malaria or other infections. And another very uh, acute and critical situation gets need to be very challenging would be if you have a blood transfusion reactions. All right. All of them cause unconjugated hyperbilirubinemia. So we must be aware of this. Um Now, this is again something which we need to be aware of. Sometimes Like, for example, we saw this topic of migraine. Your patient has been having repeated bouts of migraine, so she's been taking a lot of acetaminophen because she knows that it is safe in pregnancy. This itself can push the liver into uh, failure. Failure would be a endpoint, but it could definitely be hepatotoxic. And one goes on exploring other things and fails to realize that it is the drug which is responsible. Methyl dopa, well, in usual doses it does not, but in high dose it does. These other drugs, valproic acid, methotrexate, we would not be giving during pregnancy. Of course, OC pills, there's no question of it being used in pregnancy. Phenytoin today also, I don't think anybody is giving during pregnancy. Nitrofurantoin, however, is being given by many people, and one should be aware that it is hepatotoxic, right? Now, this is something which is very difficult to suspect and therefore diagnose, right? So, what I would like you to be clued into is that here a palpable liver which is tender should be something which makes you think of hepatic vein thrombosis. Very, very critical situation, difficult to diagnose as well as treat. But if you have this in mind, doing a ultrasound along with a Doppler, so you tell your radiologist what you're suspecting, and he or she would run a Doppler for the IVC and the hepatic vein, and this would probably clinch the diagnosis. Well, the way of diagnosing it would be a venous angiography, which in pregnancy is really reserved for absolute uh, cases where you're very sure that almost sure that this is hepatic vein thrombosis. Of course, and the treatment would be not really the obstetrician's part. You need to involve a multidisciplinary approach over there. Right? Right. Um, and this is something which probably we will start seeing more and more. The literature so far shows around 37 to some of them are showing around 40 pregnancies post liver transplantation. But as more and more successful liver transplants are happening, maybe mm, your generation and the next generation will start having to manage perhaps pregnancy with liver transplantation also. All right, so these are just some of the summary points over here. Uh, right. So again, this is suppose you see that the LFTs of your patient are abnormal over here. So how do you recognize? You look at the transaminases over there and the total bilirubin. This will give you an idea about which would be the more possible diagnosis. Of course, one does not simply run the liver function for all patients. This is more from a lab point of view, all right? And this is just a very simple visual which can help you remember what would be the uh, common liver affections during pregnancy, all right? Okay. Uh, right. Again, this is a good article to read. So for further reading, uh, how does one approach? This is a good article which has, presented it well. I've just taken a few snapshots from them. I will again share this entire article and ask them to upload in the library. So if you look at this table, it helps us very easily differentiate between these major conditions. Hyperemesis gravidarum, I'm sure many of you might have had experience of managing hyperemesis. Have you encountered any of them with alteration in the liver functions? I think it would be interesting and would break this monotony of me going on and on if we would interact in between. Have you had any experiences of managing hyperemesis in your careers so far? Do you routinely do LFTs in women of hyperemesis? Let me put it like that. Is it part of your investigative profile in hyperemesis? Okay, yes, Kartika. Yes, it is always prudent to run the liver function. In fact, hyperemesis sometimes is actually hepatitis, which is triggering of the episodes of vomiting. And of course, hyperemesis by itself can alter the liver function. So it's always prudent to run the liver function tests along with along with thyroid function tests. Yes. Okay, we have had some very severe cases of hyperemesis, even bad enough. In fact, just recently, just last week, we had a hyperemesis who became altered sensorium, etc., etc., and then uh, eventually was diagnosed as Wernicke's because of the deprivation, severe deprivation of B12. Okay, all right. So from the liver, now we move on to some of the last few things which I'm supposed to be telling you about, and that would be about ECG. Well, I do not mean to mm, belittle obstetricians, but many a times we are not very familiar with ECG. Having said that, we must know about ECG because many times it's our cardiologists who are not aware about what happens specifically during pregnancy. So, like I am often found saying, we are the masters of pregnancy and everything else that happens during pregnancy. We may not be having great knowledge of cardiology, but where it is pregnancy specific, we oftentimes have a thing or two extra to inform even our treating cardiologist. So we must be familiar about what are the ECG changes that can occur during pregnancy, and therefore it should be interpreted accordingly, right? So we know we've learned right from undergraduate days that there are a lot of physiological changes during pregnancy, and they end up causing certain ECG changes, right? And it is because of what both the anatomical uh, positioning, that is the spatial arrangement of the heart, and the changes in the thoracic ratio changes during pregnancy, and there are changes in the sympathetic system, the autonomic nervous system, as well as we know that there are a lot of hormonal changes during pregnancy, like progesterone itself causes changes which can be reflected in the ECG. Now, which is the first and very easy to understand would be the heart rate. We know that the cardiac output increases by 50%, and therefore the heart rate from pre-pregnant would increase by 80 to 90 beats also. Uh, okay, not by 80 to 90 beats. It increases by 10 to 20 beats. So even a pulse rate of 90, if the baseline was 70, if the lady was having a baseline heart rate of 80, the pulse rate of even 100 could be normal. And this reflects as a symptom of palpitation. And in the ECG, obviously you can see the heart rate as increased, right? Now, this may lead to arrhythmias. This is one of the reasons which is attributed to the increased incidence of arrhythmia, right? Other mechanisms are not really very clearly understood. It could be increase in the sympathetic activity, it could be increase in the plasma volume, right? And estrogen over here is implicated because it increases the excitability we know of the uterine muscles, and they say that it may do a similar thing on the myocardial cells, and that is mediated via the alpha receptors. Now, another change which is seen in the ECG is in the QRS axis. Now, what does the QRS axis measure? It measures the direction of depolarization of the ventricles. And what do we see during pregnancy? Physiologically, significant left axis deviation is noted. And why does this occur? We know that as the uterus becomes a abdominal organ, it pushes the diaphragm upwards, right, as the pregnancy advances. Now, this also pushes apical impulse to the left. Both elevation as well as rotation of the heart is noted. So, like I said in the beginning, there's a spatial change in the thoracic organs, right? So, enlarging uterus as well as the increase in the blood volume both contribute to the displacement, and this will show left axis deviation and will be seen in the QRS axis in the ECG. One should remember that. All right. Now, the next thing which we must know is the QTC interval. What does this reflect? This is the time taken for depolarization and repolarization. I think we need to jog our memories back to first year physiology of the heart, ventricular myocardium, right? Now, there is an increase in the QTC interval in latter half of pregnancy. So, if you do a longitudinal ECG of non-pregnant first trimester, second trimester, third trimester, you'll see that the QTC interval goes on increasing, right? And this is also attributed because of the increase in the pulse rate. Now, this is something which we really need to know and understand, that T wave inversion has been observed, especially in the third lead and some of the chest leads. Here, it is attributed to a relative ischemia. Now, what is the clinical importance of knowing this? In a normal patient, well, we can just say that this is because of pregnancy. The problem comes if your antenatal patient develops chest pain, and then you see the teen versions over here, and how do you differentiate whether she's really having a myocardial ischemia? Well, one must be very careful over here and not just attribute it to physiology. Here, one would be prudent to run the cardiac enzymes. All right. Having said that, if you're running a ECG just as a screening or say for fitness for anesthesia, one must not be alarmed by T wave inversions over here. They are physiologically seen in pregnancy. So this is just a diagrammatic thing of whatever I was trying to tell you. This is left axis deviation, and these are the T inversions over here. Okay, and changes in the heart rate. Therefore, the QRS intervals, right? Now, coming to the last bit is about the ABG. ABG, thankfully, in obstetrics, we rarely need to do, but when we do need to do, these are very critical times. Your patient is in the ICU and is probably having certain conditions which need critical monitoring of the arterial blood gases. So, what you need to know are the physiological changes and how to interpret the ABG during pregnancy. So there is a slight increase in the pH during pregnancy, and of course there is no change in the uh, oxygen pressure, but there is a slight decrease in the PaCO2. This one must be aware of, right? And the standardized bicarbonate is also decreased. Okay, and if you see the decrease, uh, it's marginal, nevertheless there is a decrease. Okay, so interpreting ABG, again, we are the ones who sometimes tell our critical care friends and colleagues that this is what is seen during pregnancy. Now, this is a very interesting article. There are very few studies like this. Now, these authors have studied the ABG during labor. And what they have done is that they have studied it in antenatal patients who are not in labor, then studied it in women who are in labor. They have also studied them in different groups during labor. Okay. For example, if I may bring your attention to this particular table, see vaginal delivery as compared to an elective cesarean section, and they found significant difference in the ABG of these. Now, even within the vaginal delivery, they saw women who had epidural analgesia, and these were women who had epidural analgesia and had oxytocin as an augmentation. And they also studied the ones who did not have any analgesia during the vaginal delivery. And very interesting findings were seen, and this really needs to be explored. It also tells us that what are the demands that go on in the physiology when the patient is in labor. I don't know if you all have heard this. We have heard this. Many of our teachers used to say it, and now I say it to my students that vaginal delivery is akin to running a marathon. That much work is done by the mother, and these ABGs actually reflect that. So do look up this article. Very, very interesting read, and maybe it would, you know, uh, if you are interested, you could also do this kind of some kind of study. Very, very interesting, and I think we all need to add to the pool of literature and understand what happens to the ABG during labor. Okay, so if you have any questions, I would be very glad to answer. If you have anything to share or discuss among your patients or anything like that, you're most welcome to. Otherwise, I would like to thank you for being present today, and do look up these things in the library. My experience with atypical preeclampsia. All right. Uh, well, atypical preeclampsia. Yes, we have had certain experiences atypical preeclampsia. Uh, like they never had any edema. Then many times we have seen that they were absolutely uh, having normal BP right till they went almost into labor, and then they have got derangement of the blood pressure intrapartum, and which go on to persist as HDP. In fact, I have had, mm, now that you're saying it, just the last week, we had a patient of twin pregnancy who was normotensive, and just we have posted her for elective cesarean section because of the first non-cephalic presentation of the first baby. Intrapartum, she had certain rise in BP which persisted on, and we had to put her on antihypertensive. In fact, we had to give her IV labetalol in the immediate post operative period, and continued with oral antihypertensive, and you won't believe this patient actually had derangement of the platelet and the liver enzyme. So she went on to become uh, a supposedly normotensive patient. So multiple pregnancy, we know that we were rather alert about it, and of course, being an institution, there was a lot of close monitoring over there. Retinopathy in 36 weeks. Okay. Retinopathy with pedal edema, normotensive, no non-diabetic. Oh my God. So probably you should explore other causes of retinopathy. I don't know if we could really attribute this to HDP, a patient of retinopathy. Probably discuss it with ophthalm colleagues, causes of retinopathy. And of course, I have had a lot of experience in the press, you know, patients developing convulsions. Some of them are not hypertensive also. And immense cases of eclampsia. I am also attached to a medical college which is in a rural area. So, very poor antenatal care of patients who land up with eclampsia even today. Anything else? So, thank you for attending. If there are any questions, you could please feel free to reach out later also. You need not come up if you are not ready with it, or later on you come up with something. You're there in the WhatsApp group, I think, of the HRO. Yes, thank you, my dear. So you could take my number from there, or you could take it from any of the mm, backend team members, and please feel free to connect. I would always be there to discuss or solve your queries. Okay. So these articles, which I have shown a few glimpses of, I'll have them uploaded in the LMS in the library. So you can go through those articles. They are good readings. Okay. So if there are no more questions, we'll call it a night over here. Okay. Anusha, I think we may end the session.
Okay, ma'am.
All right. Thank you, everybody.